Welcome to UCL's Single Best Answer series in anaesthesia and perioperative medicine. Don't worry if you don't know the answers. It's just another way of teaching and helping you develop critical thinking. Press pause whilst you're reading the question and then play when you want to see the answers. Okay, so let's look at these in turn. Of course, nothing, I'm not sure, fair enough. Let's do no harm first. In reality, if that was the case, what would you do? Well, number one, you'd ask your senior, you'd ask your SHO or registrar or consultant what the normal dose is. Yeah. And of course, in a CPSA, OSCE, in reality, if you don't know what the dose is, you'll say, I'm sorry, I don't know what the dose is. And I would look it up in the BNF and ask my consultant. Okay, this is a bit of a boring one, isn't it? So you either know it or you don't. Now, there are a few caveats to this, but basically patients staying in after surgery have a prophylactic dose of low molecular weight heparin, if it's safe, 6 hours after surgery, and then classically 6 p.m. every day from the next day. Why 6 p.m? Well, that allows us to do interventions in the day. And if those interventions, for example, putting a drain in, are high risk of bleeding, we can then delay the 6 p.m. dose. The second thing, of course, that 6 p.m. dose, by the next day, the majority of that anticoagulation will have worn off or certainly past its peak anticoagulation effect. So it will be much more safe to do procedures in the next day. So again, 6 hours after surgery and then 6 p.m. the next day is the classic thing. Now there are a few caveats for that we'll talk in the next slide. Okay, a bit of recap about low molecular weight heparins, for example, enoxaparin, dalteparin, tinzaparin. So they're given in 2 different doses, a preventative prophylactic dose, and that's the dose we're talking about after surgery to stop a DVT or PE or reduce the chance of it. There are also treatment doses if you have an established clot somewhere. Those are higher doses, therefore the treatment doses, aren't they? Of course, a few caveats. If the patient is smaller, less than 50 kilograms, or has lower renal function, we'll give a lower dose of the prophylactic or treatment dose. If the patient is bleeding, we're going to pause the idea of giving a low molecular weight heparin, and we're going to discuss it with our seniors always. And there are some situations where we don't ever give early low molecular weight heparins. Those are the situations in which case any bleeding would be catastrophic and not easy to stop. Neurosurgery and spinal surgery are those.